This is chapter 31. It's the care of patients with dysrhythmias. This starts out showing you a picture of an automated external defibrillator. This is designed for use by non-professionals in emergency situations when defibrillation is required. Um, It allows for earlier defibrillation, and when used, there's a greater chance of successful rhythm conversion and patient survival. So you will see these in a lot of places, malls, in grocery stores, schools, everywhere, because this has been shown to actually save lives. So the concepts, again, for this chapter is perfusion. And the interrelated concepts are fluid and electrolyte balance and clotting. So let's look at the conduction system. We've looked at the valves, we've looked inside the heart. Now let's look at how it works. What causes all this contraction stuff to work? Well, the cardiac muscle, if you'll remember from A&P, is self-exciting. It has its own conduction system. This is in contrast with the skeletal muscle, which requires either conscious or reflex nervous stimuli. The heart's rhythmic contractions occur spontaneously, although the frequency or heart rate can be changed by nervous or hormonal influence, such as exercise or perception of danger. It's still a system of specialized muscle tissues that conducts electrical impulses that stimulate the heart to beat. Now, this is a terribly busy slide, but it's important, and I wanted to put it all in one place so that you could connect it. So you've got your SA node, and this will show up on the EKG. This is where you're going to see this cardiac conduction system. You're going to see this as a P wave on the EKG. The electrical impulses normally beat 60 to 100 beats per minute when the sinoatrial node is in control. Then you have your AV junction, atrioventricular junction. This is where the AV node electrical impulses fire at 40 to 60 beats a minute. So it's a little slower. Takes a little longer to get down there. The PR segment on the EKG is prolonged. It's seen there. That's your PR segment. Not the P wave, but the segment. This contraction right here is called the atrial kick. Very important. Very important in cardiac output. Atrial kick. The bundle of His is where the impulse goes next, down the bundle of His. And this rate is from 20 to 40 beats per minute. Takes longer and longer as you go down. The right bundle branch and the left bundle branch, those are significant. The Purkinje fibers are the fibers that spread the impulse throughout the ventricular contraction. That's those myocytes that are in there. It spreads through the myocytes to cause the contraction. And that's the action potential which travels through the bundle of His. This and the bundle branches and those fibers, these are what causes the contraction. It depolarizes those myocytes, and then the ventricle will contract. And now the heart is in systole. So it's contracting. So it goes from the SA node to the AV node, the bundle of His, the bundle branches, Purkinje fibers, then out to the myocytes. Now, the cardiac conduction system is what you're looking at here is the SA node, the AV node, that bundle of His, the bundle branches, and the Purkinje fibers. The pacemaker cells are located within the SA node, the AV node, the bundle of His, right and left bundle branches, and the Purkinje fibers. The contractile cells are the second cell types within the myocardium. This makes up the bulk of the myocardium. 99% of the myocardium are those little cardiac myocytes. They're the muscle cells. They are responsible for causing for the contraction, the actual contraction of the heart. So all of this conduction system is to cause that contraction of the myocytes. So now we've covered the anatomy of the cardiac conduction system, but how does it work? How does the SA and AV nodes work? Well, it works through what is called, and remember in physiology, A and P, the action potential. Those cardiomyocytes have the special ability to stimulate themselves, and they do that through ion channels that allows the passage of ions into and out of the cells. So, in the cardiomyocytes, they have a fast-acting sodium channel and a slow-acting sodium channel. They have a fast-acting potassium channel and they have a slow-acting potassium channel. And of course, other things, ions are in there also, chloride and all that. But these are particularly enhanced in the P cells, and that's your SA node. They have a lower resting membrane potential than the surrounding cardiomyocytes, and they transition cells due to the channels. So, the entire cardiac conduction system is under the influence of the autonomic pathway. Sympathetic stimulation of the conductive tissues comes from what's called the cardiac plexus. Parasympathetic influence arises from the vagus nerve, which is cranial nerve number 10. Now this slide is going to show you the EKG or ECG lead system, electrocardiogram lead systems. A 12-lead ECG paints a complete picture of the heart's electrical activity by recording information through 12 different views or perspectives. It's 12 different points of view of an object woven together to create a cohesive picture. And this is the ECG interpretation. But this is how the leads are placed. Here are the areas that they would place them, and this shows you a complete picture of the electrocardiography of the heart, of the electrical activity. So, the electrocardiogram or ECG is a test that measures that electrical activity of the heart. With each beat, an electrical impulse or wave travels through the heart. This wave causes the muscle to squeeze and pump the blood from the heart. Just like we said earlier, those myocytes are activated. So a normal heartbeat on ECG will show the timing of the top and the lower the atrium and the ventricular chambers. So, this shows you each segment between these dark lines here, the dark lines above the strip, represents 3 seconds. And when the monitor is set at a speed of 25 millimeters per second, which is normal, when you want to estimate your ventricular rate, you're going to count the QRS complexes in a 6-second strip. So you would count from the one dark line over to the last dark line. You would multiply that by 10 to estimate the rate for 1 minute. In this example, there are 9 QRS complexes in 6 seconds. So the heart, you can count 1, 2, 3, 4, 5, 6, 7, 8, 9, 9. It stops right there, right before that next beat. So you can estimate the heart rate to be around 90 beats per minute. Okay, this slide shows you the complexes of the ECG. This is what it looks like, and this defines it. Your complexes are the P waves, the QRS complex, the T wave, and possibly, occasionally you can see a U wave. Now, this complex is this right here. Your segment is the PR interval, which is the interval between the P and the R wave, which would include a Q wave. ST segment, which would be just after the S wave and up to the T, and then the TP segment, and that's the segment between the T wave and the P wave of the next contraction. The intervals are the PR interval, which is that interval that is a timed interval between the P and the R segment, and the QRS duration, and that would be the width of the QR and the S, that's the width of that, and the QT interval, and that would be the distance between the Q wave and the T wave, which is a long interval. So this is what you're going to see on the ECG. Now, what does all this represent? Well, this is your normal ECG. That P wave is atrial depolarization. That's when the atrium depolarizes. The PR segment is the time that's required for that impulse to travel through the AV node, where it is delayed and through the bundle of His, the bundle branches, and the Purkinje fiber network, just before ventricular depolarization. That's the PR segment. The QRS segment is the ventricular depolarization, and it's measured from the beginning of the Q wave or the R wave to the end of the S wave. The J point is the junction where that QRS complex ends and the ST segment begins. The ST segment represents early ventricular repolarization. The T wave is ventricular repolarization. The U wave may, if you see it, would indicate late ventricular repolarization. The QT interval is the total time required for ventricular depolarization and repolarization, and it's measured from the beginning of the QRS complex to the end of the T wave. So this is a pretty important slide, just so that you can visualize in your when you're looking at an ECG to see exactly what's going on. Now, why is all this important? Why do we need to know about ECG rhythm analysis? Well, obviously here we want to know how fast our heart is going. Is it slow or is it fast? Is it regular or is it irregular? Does it have P waves? If it does, what do they look like? You want to know what the PR interval is. Is it long or is it too short? This can cause rhythm problems. So we need to know that. So we measure the PR interval. We measure the QRS duration. Is it wide or is it narrow? If it's wide, that means it's taking longer to travel through the QRS, the ventricle. So we need to see, is it wide or is it going through fast? You want to look at the ST segment. Is it elevated or is it depressed? That can represent um, um, perfusion problems. Assess the T wave. That is where you're going to see repolarization. What does it look like? You're also going to measure the QT interval because that is the total time that's required for ventricular depolarization and repolarization. So the time it takes to beat and then repolarize for the next beat. So that's important to know because sometimes it can be delayed, and that's not good. So now let's just look at a good old normal sinus rhythm. It's called a normal sinus rhythm because both the atrial and the ventricular rhythms are regular. Sometimes you'll see a little bit of variation, but it's not much. Um, Atrial and ventricular rates are both the same um, amount each. They're 83 beats a minute. There's only one P wave before each QRS complex, and all the P waves are of a consistent morphology or shape. They all look the same. The PR interval measures 0.18 seconds and is constant. All of them are the same. The QRX complex measures 0.06 and is constant. That's important. You gotta know the normal before you can figure out the abnormals. Okay? This is a normal. So what makes it normal? Because it's between 60 and 100 beats per minute. They are regular beats. The atrial, the P wave, and the QRS are regular. The P waves are present. They're consistent. And one P wave is before each QRS complex. The PR interval is 0.12 to 0.20 seconds and constant. In this case, it was 0.18. So this is normal. The QRS duration is between 0.06 to 0.10 seconds, and that too is normal. In the sinus rhythm we saw just a minute ago, it's 0.6 seconds. So this is very important that you know this rate and what the P wave, the PQR interval, the PR interval, and the QRS interval. Those are things that you need to really be aware of. What is normal? So I'm going to show you a couple of sinus rhythms here. Both of these are sinus rhythms, but the top one is a little bit faster than 100. It's 110. So that makes it tachycardic. It's still sinus. It's coming from the P wave. You still got P waves. You still got a narrow QRS. You still got everything that is a sinus rhythm. It's just tacky. So that's a tachycardia. On the second one, it's slower. So it's 52 beats a minute. Still has a P wave, still has a narrow QRS, but it's slower. So that is called a sinus bradycardia. Now there is a variant of the sinus arrhythmia, and you see this mostly in children. There is a little bit of a change when that because when they breathe, the intrathoracic pressure causes a little delay. You're still going to have a rate of 60 to 100, and the atrial and ventricular rhythms may be a little bit irregular. You may see a longer duration during when they breathe. So you're going to see still one P wave before each QRS, and a normal constant PR interval and a normal constant QRS. So this is a really just a variant. Now, dysrhythmias also can be called arrhythmias, um, but common dysrhythmias that you are going to see, and I promise you're going to see these in your patients, especially if you work in the cardiac area, um, you're going to see premature complexes. And this can be bigeminy, or trigeminy, or quadrigeminy. And that's exactly what it says. There's a repetitive two-beat pattern in bigeminy. It's repeated 3 times in trigeminy and then 4 times in quadrigeminy. So it's every fourth beat, every third beat, or every second beat. Those are premature. They're premature complexes. Um, Brady dysrhythmias are very common, and that's when the heart rate is less than 60. And a lot of athletes have normal heart rates of less than 60. Tachyarrhythmias or tachydysrhythmias is heart rates that are more than 100. And of course, you get that with stress, with exercise, with all sorts of things. So it's just an irregular or an abnormal heartbeat. That's what dysrhythmia is. Premature complexes occur when a cardiac cell or a cell group other than that sinoatrial node becomes irritable, and it fires an impulse before the rest of the sinus impulse is produced. So this is these are common um, things that you may see. Now let's talk about this once again. Sinus tachycardia, this is a sinus dysrhythmia, is over 100 beats per minute. Sinus bradycardia is uh, less than 60 beats per minute. It's a slower heart rhythm. These are still going down the normal pathway. It's regular and the node is normal. The SA node looks normal. So these are sinus dysrhythmias. So here's a picture of sinus tachycardia. This is a heart rate of 110 beats per minute. You can see, you can count them, and this is a 6-second strip. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So that's 110 beats per minute, which makes it all normal. P waves are all normal. QRSs are all going the right way, and they're all narrow, and nothing is abnormal except the heart rate. So it's a sinus tachycardia. That's what it's called. This is a sinus bradycardia. Again, 6-second strip here. You can count them. 1, 2, 3, 4. It's 40 beats per minute. So this means that it's lower than 60. It all has P waves. There's no extra anything in there. P waves are all the same. They're all normal. And the QRS is normal. It's narrow. So this is a sinus bradycardia. It is initiated by the SA node. It's just slow. So now let's talk about what we do if it's too slow. You're going to assess your patient always, 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 always. You start with assessment. And when somebody has a slow heart rate or they complain about fainting, then you're going to assess them for syncope and dizziness and a weakness or confusion. And also their blood pressure would probably be low. And they may have diaphoresis or shortness of breath. Sometimes, if this is caused by a specific reason, such as myocardial ischemia, or if they have a problem with a conduction system that causes this slow heart rate, then they might need temporary pacing if they are unstable. And they would be unstable if they had dizziness, weakness, confusion, hypotension, or shortness of breath, or diaphoresis. So what they do is they will put in a temporary pacing catheter. And I've done many, 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 many of these, or helped with them. I've never put one in, but I've helped with them. This is a non-surgical intervention. They put it in through the subclavian, and it provides a timed electrical stimulus to the heart when either the impulse initiation or the conduction system of the heart is defective. And there are many reasons that that can happen. They can have a sick sinus syndrome. Their P wave may be what a defective P wave. Um, they also can do transcutaneous pacing, which we did in the unit when I worked in ICU. We would use two large external electrodes, and they're attached to a external pulse generator on our defibrillator, and this is what we do in an emergency, and it's you can see when it is in action, it's very pronounced. It provides ventricular pacing when somebody is very bradycardic or or they're in asystole. Transvenous pacing is used placing an electrode into the right ventricle through the subclavian, or they can use the femoral vein. Um, It may be synchronized on demand or asynchronous, which would be a fixed rate. And this just shows you where it's placed. If they do a permanent pacemaker, it would be placed in the shoulder, and they're very small, and they're placed to do the same thing. Let's talk about premature atrial complexes. These are very, very, very common. This is called a PAC. It's an ectopic focus of atrial tissue that fires an impulse before the next impulse is due. So it's premature. It can be caused by stress, fatigue, anxiety, inflammation, caffeine, nicotine, alcohol, and drugs. So these are fairly common. A lot of people who drink a lot of coffee may have these. Anxiety, when you have anxiety or stress or get really, really tired, you may feel like a little butterfly in your throat, and sometimes that's what it is you're feeling it, or you feel your pulse and you feel a little extra beat, and that can be a PAC, a premature atrial complex. So, supraventricular tachycardia, which is called SVT, is a rapid, abnormally fast, or erratic heartbeat that affects the heart's upper chambers. The upper chambers. It's above the ventricle. This is called a dysrhythmia, and it is can also be called SVT, can be called paroxysmal supraventricular tachycardia also, because it doesn't happen all the time. It happens occasionally, so it's paroxysmal. This happens quite a bit in healthy young people, especially women who have some mitral valve problems. My sister had that, and they put her on a calcium channel blocker. So let's talk about a perfusion problem. This exemplar is called, the one we're using here is atrial fibrillation. This is a perfusion problem. The pathophysiology is that this is a very chaotic rhythm that has no clear P waves. There are no atrial contractions, and there's a loss of that atrial kick that we get when we have the P wave going through correctly, and we have very, very irregular ventricular response, which causes a very chaotic looking rhythm. It's irregular. It often is very rapid, and it can increase the risk of strokes, heart failure, and other heart-related complications. During atrial fib, the heart's two upper chambers, the atria, beat chaotically and irregularly. They are out of coordination with the two lower chambers of the heart, which are, of course, the ventricles, and it causes a terribly, terribly irregular rhythm. And that's the key for atrial fib is irregularly irregular. So let's talk about atrial fib. What is the etiology and the genetic risk? Well, it's the most common heart rhythm disorder, and thus it has um, some people who have families who have atrial fib. It's not uncommon for several people in a family to have it. Everybody has a higher risk for developing atrial fib with increasing age. The incidence of the familial form of atrial fib is unknown. However, recent studies suggest that up to 30% of all people who have atrial fib without an identified cause have a history of the condition in their family. So that would be a familial problem. So most cases of atrial fib are not caused by inherited mutations. They are caused, it's very common after heart surgery, when people who have an enlarged heart, which is also called cardiomyopathy. Chronic lung disease can also cause atrial fib. Congenital heart disease can, coronary artery disease, heart failure, valve disease, hypertension, and pulmonary hypertension can also cause um, um, atrial fib. So it is, you can have genetic problems, but most of the time it's due to actual heart conditions. So what do you got to do? Of course, we're going to do a history. You're going to look at a prior history of atrial fib or other dysrhythmias. You're going to look for heart disease. What are their labs? You're going to do a physical assessment. You're going to look, you're going to always assess an apical pulse, because you can't really feel a good, you have to count it for a minute because it's irregular. So you want to count it for a full minute to get your pulse rate. Um, it will be irregular. Um, the symptoms will depend on how fast the ventricle is beating, if it's able to fill or not. It can cause very poor perfusion, and some people may be very symptomatic with it. They can get very anxious. They can have palpitations. They can have fatigue, lightheadedness. They may have shortness of breath. they can't exercise, and they have weakness. So people who have atrial fib usually feel it, and it makes them very uncomfortable, and it does decrease their cardiac output. And the assessment that you would do would be, of course, an EKG or ECG. Our concern here is the potential for embolus formation due to that irregular cardiac rhythm. The atrium is beating very fast, so it's not the blood can pool in there, and it can cause a person to have a stroke. So when standard risk factors for stroke are accounted for, atrial fib causes a five-fold increase of ischemic stroke, and it causes about 1 in every 7 strokes, atrial fib. So strokes caused by complications from atrial fibs tend to be more severe than strokes with other underlying causes. And this happens, a stroke happens when blood flow to the brain is blocked by a blood clot or fatty deposit caused called plaque in the blood vessel lining. So this is a uh, major cause for strokes, embolytic strokes. So we know that we're going to have to do to prevent embolus formation, we need to give them anticoagulants. So long-term anticoagulations such as Coumadin or direct oral anticoagulants that you see on TV all the time now, the Pradaxa, the Xarelto, the Eliquis, those sorts of drugs are selective thrombin inhibitor drugs. And also, we give medications to control the heart's rhythm and heart rate, such as beta blockers, such as metoprolol or the esmolol, is used to slow that ventricular response. And also, for patients who are in heart failure, sometimes we give them DIG, digoxin. These medicines used for rhythm control of atrial fib also include Rhythmol or quinidine or flecainide, or amiodarone is also given. Blood thinning medicine to prevent those blood clots are the major thing. That's your major non-surgical intervention. And then surgery, sometimes they will go in and that's when they would do ablation. They would go in to create lines that would cause that rhythm, the conduction to blockage, so that they wouldn't have such a fast heart rate or ventricular rate. So sometimes they will go in and do that. It's a pretty common dysrhythmia, but it's a very detrimental one. So when they go home, they need to know about taking care of themselves when they're on medications, absolutely about the uh, medication for the blood clots, any Coumadin therapy, self-management education about it, keeping their environment safe, and knowing that they would have less stamina. They may need a case manager or a care coordinator to assess their needs for additional healthcare resources, and then coordination of access to other services. So a case manager is a good thing for this patient. How would we evaluate their outcomes? Well, we want to make sure they don't have a stroke, that they remain free of the emboli formation, and that they remain free of heart failure due to that irregular heart rate and rhythm. So you want them to have a regular heart rate and rhythm, and hopefully the medications will help them to maintain or to have a regular rate, or at least slow down the rhythm so that they get a better cardiac output. Now, this is important in people who have atrial fib, that they be monitored, that they maintain their appointments and their medication routine, because these people are very much at risk for heart failure and strokes. Now let's talk about ventricular dysrhythmias. This is premature ventricular uh, complexes. Ventricular dysrhythmia is a disturbance in the normal rhythm of the electrical activity of the heart, and this arises down in the ventricles. Well, the ventricles, if you'll remember, are the major pumping force. So dysrhythmias here can be a good bit more complex than the atrial arrhythmias. So conditions associated with cardiac dysrhythmias include myocardial ischemia, myocardial infarction, electrolyte imbalance, drug toxicity, and degeneration of the conduction system by necrosis. That would be from an acute MI. So a dysrhythmia can be the result of a disturbance in the ability of that cardiac or myocardial cell to conduct that impulse, the conductivity, and it's a disturbance in the ability to initiate and maintain an inherent rhythm, a spontaneous inherent rhythm or automaticity, or a combination of both. And this is how they are classified: as premature PVCs, premature ventricular complexes, and that's a PVC, a ventricular tachycardia or VTAC, ventricular fibrillation, VFib, and a ventricular asystole, which is complete standstill. So these are pretty significant factors. I have a table here that will tell you what about the PVCs, the VFib, or the VTAC, VFib, and standstill. So if you want to look at these, know that electrical activity, the early ectopic beats arise from the ventricles, are called PVCs. They're early. Your atrial rate would be regular, your ventricular rate would be irregular. Your QRS complex would be wide and distorted. It's usually longer, the T longer than 0.14 seconds. That's that irregular beat that you see, the early beat. It can occur singly, in pairs, or alternating, and we call that bigiminy. It can alternate with regular sinus beats, and these are the conditions that you can see it in. I'm not going to go through all those. You can read them. The TAC is 3 or more ventricular contractions in a row that is disassociated from the atrial contraction. So it's 3 or more premature ventricular contractions. In sustained VTAC, there are no identifiable P waves. The ventricular rate can be between 100 and 220, and the ventricular rhythm may start and stop suddenly. In VFib, you have disorganized, ineffective contraction of the ventricle. You have 0 P waves. The atrium is not beating at all, and this is very complex looking rhythm, chaotic. There are the QRS complexes are not there. It has a wavy baseline, and this can happen in drug toxicities, and also in myocardial infarction, irritable ventricle. Then ventricular asystole is called cardiac standstill. Are nothing. There's no atrial rhythm, no QRSs, no P waves, no T waves, and there are no ventricular rhythms. And all of this can be caused by the listed causes here. So that just tells you the nature of the ventricular rhythms. They're a bit more complex than atrial rhythms and can cause much more damage. What I want you to see here is a couple of the ventricular dysrhythmias. You see this PVC. It's very wide complex and it occurs early in the cycle. So usually there will actually be a complete called a compensatory pause. It is between those two regular beats, so there's a compensatory pause here. And this one's occurring occasionally. Then below that you can see that there are different foci. This one is called multifocal PVCs. One is negative and one is positive. So, if you have a ventricular dysrhythmia, which arises in the ventricles, the types of ventricular dysrhythmias, of course, include the premature PVCs. They can have one focus or multifocal. Ventricular tachycardia, which can lead to ventricular fibrillation or sudden cardiac death. Ventricular fibrillation results in death if not treated immediately, and ventricular asystole has zero cardiac output and it occurs, and that's called full cardiopulmonary arrest. So when you have a life-threatening event such as this, if the patient is unable to provide a history, then you have to obtain it from a witness. Many people with suspected cardiac dysrhythmias describe a history of symptoms indicating periods of decreased cardiac output. They feel faint, they feel diaphoretic, they feel their cognition changes. And when you do a physical examination, lethal dysrhythmias such as VFib can lead to full cardiopulmonary arrest. And if the patient does not have adequate airway, the breathing and circulation, your ABCs, then you have to initiate cardiopulmonary resuscitation. If the patient is stable, you would do a complete head-to-toe physical examination, of course, focused examination, but they may have fallen, they may have bruises and things that you need to check on, especially head trauma. And there's psychosocial evaluation. This is scary. I mean, if they're not dead and this is a life-threatening event and it causes a lot of anxiety and fear because you think it could happen again. These people need a full workup, need to see what's going on, and you want to assess the ability of your patient and the significant others to cope. This is a very life-changing situation. So, these premature ventricular complexes result from increased irritability of the ventricular cells. This is quite often seen in people who have cardiac ischemia, and that is a key factor in the development of ventricular premature beats, or ventricular irritability is caused by ischemia. This can cause this next dysrhythmia to happen. These premature ventricular complexes can cause V-tach. The ventricular tachycardia is a repetitive firing of irritable ventricular ectopic foci or uh, ventricular beats, and it's usually at 140 to 180 beats a minute or more. So you can count on the 6-second strip, you can count the complexes, and this one's at 166. Now, what's the problem with this? Well, V-tach can cause V-fib, and the V-fib is a result of electrical chaos in the ventricles, and there's no cardiac output here. The ventricles are not pushing out any blood. It's quivering, and it's causing, this is coarse ventricular fibrillation here. You can see it looks like it tries to pump some, but it doesn't. So this is life-threatening. This is ventricular asystole. It's called ventricular standstill. It's a complete absence of any ventricular rhythm. This has one complex in this 6-second strip here. It's called idioventricular complex. It is not doing any pushing out any blood. There's no uh, cardiac output here. So this is called ventricular standstill. This requires CPR, an advanced cardiac life support. So this is when you use high quality CPR, and you are going to do that according to your BLS. When you have graduated, or before if you wish, but usually after you graduate, you can do advanced cardiac life support. That is something that is encouraged if you work in the hospital, and especially in EMTs or paramedics. They use advanced cardiac life support, and these are your first responders, so this is super duper important for them. This is also used in the units and then ED at the hospital. These are medications that are used in cardiopulmonary resuscitation and defibrillation. These medications are the ones that you would know about in ACLS. You would give epinephrine, which is a catecholamine. It's a cardiac stimulant. It's given every 3 to 5 minutes. Amiodarone is used for ventricular dysrhythmias, and it's used for V-fib and pulseless V-tach. If you feel a pulse with V-tach, you do not do CPR unless the patient is in acute distress, and then they would do a cardioversion. So you would give this for V-fib or pulseless V-tach. It prolongs that action potential and helps with repolarization. Lidocaine can be given for dysrhythmias, and that it will help manage PVCs or ventricular tach with a pulse. Beryllium can also be given to help with dysrhythmias. This will help manage PVCs or V-tach. And procainamide can also be given. This will help with the dysrhythmias and manages PVCs or V-tach. So all of these are just medications that may be given to a person who is having dysrhythmias, especially lethal dysrhythmias. If you can, the best thing to do is defibrillate a patient who is in a ventricular rhythm. Now, it can be an asynchronous defibrillation is always asynchronous countershock that depolarizes the whole myocardium simultaneously, and it stops that reentry, that progression of ventricular beats, and it allows that sinus node to regain control of the heart. So this is very important that this is done quickly and should be done immediately upon finding that they are in ventricular fibrillation. So the automated um, external defibrillator is used for it allows for earlier defibrillation. If you have one on site, they can get it. It will analyze the rhythm of the patient or the victim, and it will call for defibrillation when it's needed. And when that is used, there is a much greater chance of successful rhythm conversion and patient survival. So this is a great thing to be aware of wherever you are. Where is the AED? Now, sometimes people who have had episodes of VTAC or VFib that's not caused by myocardial infarction, they may require an implantable cardioverter defibrillator. So the first priority, of course, is always to maintain their ABCs. And if they're not having a cardiopulmonary arrest, you want to maximize the amount of oxygen that's available to the heart muscle. So you're going to encourage the patient to rest in bed until the symptoms are treated and they subside. You want to remain with the patient to ensure that they are resting and that you help allay their anxiety. Some patients who have PVCs, you want to help reduce their stress to help limit the incidences of the dysrhythmia. Sometimes they need a referral to a support group. Encourage them to decrease the amount of caffeine intake in the diet, and also know what is in the ingredients of over-the-counter medications, and to help them not smoke and join a exercise program. Now, if they're having problems and these precipitating factors do not limit the dysrhythmia, then they may be placed on medications. Of course, the most devastating outcome of ventricular dysrhythmia is sudden cardiac death. And if they survive that episode, then they need to talk about it and know what can be done to prevent. And that's when this would be indicated for patients who have experienced one or more episodes of spontaneous sustained VTAC or VFib that's not caused by an MI. This is when they may do an implantable cardioverter defibrillator. It can be transvenous or it can be done subcutaneous. Now, they can wear a cardioverter defibrillator vest, and that is worn 24 hours a day except when they're showering or bathing. Now, this can be very um, disconcerting when this goes off. Can you imagine being walking down the street and suddenly you get a jolt of electricity because you've gone into VTAC or VFib? So these people have to be aware of the consequences of having this. They are not encouraged to drive and to do a lot of um, heavy equipment or use heavy equipment. They need to know uh, the what to do when this happens. So they need emotional support, and they need, of course, if they do not survive, then family would need support also. So you need to be aware of the consequences of having an implantable cardioverter defibrillator. Let's look at a case study of a person who has a history of tachycardia. She's 33. She doesn't feel good, and she comes to the ER, and they put her on the monitor, and her heart rate is between 160 to 180 beats per minute. She's short of breath, has palpitations, and weakness. She's very, very anxious, and her blood pressure is uh, 88 over 56. What are you going to do first for this patient? Well, obviously, my thinking, I hope would be your thinking, is that we need to give her supplemental oxygen, which would be my first choice. So yes, you first of all, you're going to put 2 liters of oxygen on her per nasal cannula. This will help supplement the oxygen in her blood that her heart needs. So later, your client is still in SVT, 150. She's having some palpitations, but she feels some better. So which action does the nurse anticipate will be ordered by the healthcare provider? Are they going to, well, she's already had an EKG. Are you going to just sit there and wait? Are you going to run her to the EP lab to have ablation? Or are you going to give her adenosine? Now, adenosine is a medication that can convert medically, can convert an atrial arrhythmia or dysrhythmia, and this would be followed by a saline bolus. So what we're probably going to do is give administration of adenosine. It will terminate this acute episode, and it's given rapidly, and I mean rapidly. You use a stopcock, and you have both your adenosine and your saline bolus ready, one on each port. And you will give the adenosine, or the nurse who's been taught how to do this. You do not order it yourself, nor do you give it unless you've been taught how. This is given very, very rapidly. IV push, just as fast as you can give it. And it's followed by a saline bolus. So we give this to terminate that because it hasn't stopped, and it can cause cardiac ischemia if it continues, and certainly the patient is uncomfortable. So waiting just allows that to continue. EKG is not going to show you anymore, and it's certainly not time yet for the ablation. It may be recommended later as a long-term treatment. So, after we give the IV adenosine, the SVT is resolved. Now, something you need to know about adenosine is when you give it, it will cause a cessation, so to speak, of the heart. You'll see a long interval where there's no activity, and then it will give the time for the SA node to come back into play and start a normal rhythm. So it can be very scary, and the patient can feel it and say, "Whoa, whoa, that felt funny." So now we've called in a cardiologist who is consulted, and then they talk about treatment options. So the preferred treatment for recurrent SVT would be dependent on if it's recurrent, how often it recurs. And so the ablation might come into being here. So the preferred treatment for recurrent SVT would be to go in, EP lab, electrophysiology, and look to see what's causing it, and then do an ablation. If it is a continuous problem, they would go to the EP lab, the electrophysiology laboratory, and they will look at it. They will map them. The radiofrequency ablation is a procedure that can cure many types of fast heart rates. And they go in there and look at it, and it takes a good little while, and they'll try to cause it to recur in the lab so that they can permanently damage that small area of tissue with heat so that it's no longer capable of generating or conducting electrical impulses. And if it's successful, then that will prevent that dysrhythmia from happening again, and it is considered a cure. So in this case, I am going to look at these questions. So when you're working in a clinical setting, which dysrhythmia does the nurse identify as most common? What is the most common dysrhythmia? As we've said before, the most common dysrhythmia, atrial fibrillation, is seen in clinical practice. It can impair the quality of life and cause considerable morbidity and mortality, largely related to clotting concerns such as we talked about, the embolic stroke, a deep venous thrombosis, or pulmonary embolism. It can cause all of those. Mostly it's the stroke. So our second question is, you are caring for a client with episodes of spontaneous sustained ventricular tachycardia who is to have an implantable cardioverter defibrillator placed. What is your priority nursing action? So when we look at all of these, what is your priority? Are you going to teach them or assess them for the ability to cope with their discomfort and fear, provide teaching about electromagnetic interference, that's the microwave thing, prepare the client for transport to the EP lab, or monitor for dysrhythmias, bleeding, and cardiac tamponade? Now, your patient has not had this put in yet, okay? So look at your stem here and tell me what your priority nursing action is for somebody who's going to have an implantable cardioverter defibrillator placed. So what is your priority nursing action before the patient has it put in? Your priority action is to make sure that you have talked with them and that you have assessed them for their ability to cope with the discomfort and fear associated with an internal defibrillator. Then you can do the other things. They will go to the EP lab for placement, and you will monitor for complications, and then you will do discharge teaching. But you've got to see if they're going to be able to cope with this defibrillator, because they have to know what the consequences of it firing, what can happen. So you need to see if they have a psychologically understand this. So you have a new patient and they have a new diagnosis of atrial fibrillation, and they tell the nurse, I feel fine. There's nothing wrong with me. What is your appropriate nursing response? Atrial fib can cause clots to form from irregular blood flow in the heart. Atrial fib is a condition we must admit no matter what. Atrial fib leads to death of the heart muscle. Atrial fib can cause cardiac output to increase. Now, what is your appropriate and honest answer here? I hope you said A, because people can have atrial fib and they may feel okay. They may be asymptomatic. And some people do have to live with long-term atrial fib. They have to be or need to be anticoagulated because of a the increase in the risk of embolus formation. So they have to be put on anticoagulants to decrease that risk of embolus due to the irregular cardiac rhythm. Atrial fib does not cause death of the heart muscle, nor does it cause the cardiac output to increase. It causes it to decrease. The cardiac output will decrease due to the shortened filling time in the atria, which contributes to the development of heart failure due to altered conduction. And people who have atrial fib are not automatically admitted to the hospital.